topic of the day.
Treatment of cirrhosis. I think we have some objectives.
That's right. So our learning objectives is understand the screening strategies in cirrhotic patients that can reduce mortality, be able to select best treatment strategies for complications of cirrhosis, and know what medications to avoid in cirrhotic patients. Because cirrhosis was 100% fatal in the past. I think we're changing the path a little bit now, but.
Yeah. And this cirrhosis is, I like this article because it's generic, right?
Yeah.
It fits anybody with scarring of the liver, and it just means their liver's scarred for whatever reason, and they have portal hypertension, and how do we treat those people? And
Yeah.
it cleared up some things for me, especially in regards to beta blockers.
Yeah.
Because there was some controversy, and I think I understand it better.
I'm not sure I do, but we'll talk about that later.
But we'll find out if I know it any better.
But I mean, truly cirrhosis is just, right, fibrotic changes of the liver, but it's not, to me, when I think about cirrhosis, I think people tend to focus on that fibrotic change, but that's not what kills you. It's the vascular changes, and that's not just within the liver. Because it releases nitric oxide, your splanchnic bed dilates when it shouldn't. Your pulmonary bed constricts when it shouldn't. It messes up your circulatory system everywhere, and that's eventually what kills everyone too.
Yeah.
Some people die of.
Some of the things what people are getting cirrhosis from is going to change.
That's
but our
very true.
treatment of it, so more people are going to have NASH going forward.
Yeah.
Due to the medications that we have, you're not going to see as much cirrhosis from Hep C. I'm sure of that.
So I think it's important. I thought we'd just add, it's not on the handout, but what other diagnoses of cirrhosis are, because again, treatment, successful cure of hepatitis C is going to change what you have to think about. It used to be you could assume that that was it.
Yeah.
Or alcohol, or NASH, like you said. So, any other ideas on what causes cirrhosis?
Primary sclerosing cholangitis.
Very good. Yeah. Biliary disease. Yeah.
Primary biliary cirrhosis.
Yeah. How about if I had COPD?
Bronze diabetes.
Bronze diabetes,
Oh
my
boy.
favorite.
Hemochromatosis.
Yeah, hemochromatosis. What if I got COPD and cirrhosis?
Alpha-1.
Alpha-1 antitrypsin. Yeah. And then there's you can never go wrong saying autoimmune. That gets everything.
Medications.
Right. What if I had I was a man with neurologic changes in my 40s.
I have one of these running around.
Yeah.
Unfortunately, it got missed until he was psychotic, and that impairs our ability to care for him today.
Right. Wilson's disease.
Yeah.
Yeah. So I think that's important to know. So.
Yep.
Yep.
So one of the things I liked about this was, I think when we think of cirrhosis also, we think of decompensated cirrhosis, right? And we do have a lot of that here at the VA. We have a lot of people with the ascites.
That's what you see a lot, because they keep coming in.
Yeah, because we see them a lot. And one of the things that helped me in the article was, if you have decompensated cirrhosis, do you have any idea what their life expectancy is? It's on average less than 2 years. And that is, of course, if you have alcoholic cirrhosis and you're able to do abstinence, now that number changes, because almost 2/3 of those people are alive at a year if they can, or at 3 years if they can stay off alcohol. But if they have something that's irreversible or they're going to continue to drink, less than 2 years. And does that, to me, that changes a lot how I think about that person and their care, right?
And how I counsel them.
Versus compensated cirrhosis, life expectancy is 10 to 15 years. So I think...
and that should change our approach to cirrhosis too, because we focus on the people with the, what I want to call end-stage disease.
Yes.
I don't think we have enough focus on prevention of early cirrhosis. And aggressive, I think what we can do in an outpatient clinic is have very aggressive treatment of the sequelae of cirrhosis. And I don't think that we're optimizing those opportunities right now, so.
Agreed. And so what are the complications? What gets these people?
Ascites, hepatic encephalopathy, and gastrointestinal bleeding.
Yeah.
Excellent.
Infection.
I'm going to throw infection in there too.
Yeah.
Your spontaneous bacterial peritonitis.
And, do you have the question form that's not on the handout?
Yeah, so when you diagnose somebody with cirrhosis, what type, so we talk about really what we want to do is prevent sequelae, what type of screening should you initiate right at diagnosis? Doesn't matter what stage you've diagnosed them at?
Hepatocellular carcinoma, EFP,
So,
ultrasound.
right, correct, screening for hepatocellular carcinoma, because regardless of the cause of your cirrhosis, you're at risk for hepatocellular carcinoma, which is also a major cause of death. How do you screen for that?
EFP or ultrasound.
An ultrasound every 6 months for the rest of their life. And I think one thing that is a new question is, so if a patient has hep C and cirrhosis and you cure their hep C, it's been shown actually that some of that fibrosis can be reversed, but as long as they stay cirrhosis, they need that screening forever. I see sometimes people like, oh, it's fixed, but it's the cirrhotic liver itself that goes to hepatocellular carcinoma. It's not the fact that there's active virus in there causing the hepatocellular carcinoma. I think that's neat. What other screening process do you have to start the diagnosis of cirrhosis?
EGD,
EGD, yeah?
Excellent, yeah.
What are you looking for?
any varices.
Yep, looking for varices, because again, that's something we can actually treat and intervene on in many different ways, so.
Yeah, should we skip ahead to that rabbit hole?
Yeah.
Like medication?
Yeah,
So
let me see, you're gonna
beta
clear
blockers?
things up for me?
Why? Well, you know, so if you find, so a third of these people get varices, right? So that's a high number. And I'm sure you guys have, by this time in the year, have had somebody with the variceal bleed, which are awful, dramatic, and, you know, very difficult. They can
Very
be
life-threatening.
life-threatening bleeding. So what do we want to do for primary prevention? So you have somebody that come in, you make the diagnosis of cirrhosis, and you order your screening EGD, and you find varices. And so what's the next step?
Propranolol.
Well, people with liver disease and propranolol might do worse, right?
Oh, yeah.
Because they get hypotensive.
It's a trap.
Right, it's a trap. 'Cause- so there was debate about when
There's
to
no
do this,
consensus.
and I think the article that we'll post. So we want to use beta blockers because they reduce portal pressures. You reduce the chances of variceal bleeding. The problem is if you start them too early, it doesn't do anything, right?
You're taking something for nothing.
You're taking something for nothing. And so once you have varices, you definitely want to be on them to
Yeah.
prevent bleeding. If you don't have them, you probably don't need them. And then what's the natural history of cirrhosis? A lot of these things we can't change.
Remember, it's a vascular disease. So what is
And
what is happening?
what comes to mind when you see some of these people when they're really sick, they're decompensated? What's their blood pressure?
Low.
It's in the
low.
tank, yeah.
Right, and then what are some, they get hepatorenal syndrome,
Mm-hmm.
and they all have some of the lower sodiums we've seen.
Yeah,
They'll walk in here with the 125,
Yeah.
the 120, 127.
that's a high number for them.
Yeah, yeah, exactly. So what's going on? The disease is advanced, right? And they, all of a sudden they get a huge amount, they get vasodilated everywhere.
Right.
And so they have renin-angiotensin,
They can't
aldosterone.
compensate
They
because they can't constrict.
And then at that point, and I think the mean arterial pressure they used in here, which I didn't find terribly helpful, I like their rule of thumb of if the patient's getting renal insufficiency, if their sodium's really low, or if their systolic's less than 100, they throw the beta blockers away.
Yeah, at that point, your mortality
Yeah,
from other things is going to be from the low blood pressure.
Yeah.
Because you get into hepatorenal, your mortality is very high, and that's,
Yeah.
they can't perfuse the kidneys because we're giving them a beta blocker that's lowering the perfusion as well. Now, I had seen something in a Lancet article about carvedilol. It's getting studied quite a bit, and maybe, I think a lot of the data is retrospective, but I think people are using that because the retrospective data at least shows it's better than propranolol.
yeah.
But I also think it's a more potent blood pressure medication, and so I think that's what has to get studied carefully.
Mhm.
Because if it progresses you further to hepatorenal quickly, even though it lowers your portal hypertension somewhat, and decreases variceal bleeding, we're not sure of those kinds of things because it hasn't been used enough. So
Yeah, so if you're starting to get to the point where you're not perfusing, then your life expectancy is so limited. Remember, decompensated cirrhosis, you're looking at 2 years or less.
yeah,
And so then it's okay to stop the beta blockers. I think in the past we struggled with trying to push beta blockers on these people in an inappropriate
because they were
manner.
bleeding and
They were
something
bleeding,
like
and
that.
we thought we were doing well for them, and in fact, probably we were
Doing more
not.
harm.
Yeah, more harm than good.
Mhm.
Oh, and then one thing that briefly we'll get into it more. What's some other things like they came in and they're confused? What's likely to have happened? Got mental status changes, and they're encephalopathic. the hepatic encephalopathy. What do you guys, what do you counsel them? What do we do?
Ammonia levels are high, so
Yeah.
increase protein intake, and if you're prescribing
Compliance.
lactulose,
What's that?
Said compliance.
Compliance, yeah, and interesting, we're gonna talk about hepatic encephalopathy next week, but, and I used to be a big like, oh, don't go out and eat, but are these people are malnourished, right, when you see them? And so the article suggested doing good education on compliance and then having them eat at night.
Or even take supplements like your Ensure. So eat high protein, but eat it at night. For some reason, that tends to initiate less encephalopathy, but it
Yeah.
keeps them nourished.
So that was a change for me before because I think we've been so dogmatic about
We have.
avoiding
Oh, you had a
protein.
steak, now you're encephalopathic.
Exactly.
Bad
so
on you.
Yeah, we blame the patient.
Yeah. No, literally, that's
No,
what
we
would do
did.
that.
Oh my god.
No more steaks for you.
Oh, let's see. Pain management. That was another thing I liked
I
about
like that
this.
one.
So, if somebody has got decompensated cirrhosis, they're likely to live under 2 years. And I think one of our obligations as physicians is to treat the pain that they have. And these people are very uncomfortable usually, right? They're sort of 9 months pregnant.
Yeah, all the time.
And obviously, you want to manage their ascites with medications, or if we can't, then we have to do paracentesis. But what can we give them for pain management options? Oh no, their liver's gone. Tylenol's out. And gee,
No, they
whiz,
can
a lot of
stop
these
Tylenol.
meds go through either the kidney or the liver.
Everything goes through the kidney or the
Pretty
liver.
much.
They can still have Tylenol, but less than 2 grams a day. And then you have to be careful with the opioids because those are hepatically cleared.
Yeah.
But I think tramadol is okay.
Yeah,
Yep.
Not to
Tylenol.
say that some of these patients don't end up on
right.
opiates.
Yeah.
And what kind of pain med do you absolutely have to avoid? Which is why it's good that Tylenol actually is usable. So say they got some arthritic pain or something like that.
NSAIDs.
NSAIDs, right. Because that can literally tip them over into hepatorenal and cause death. It can cause a
Yep.
rapidly progressive hepatorenal because of its effect on blood flow to the kidney.
Yep.
So,
PPIs should be avoided because they think that PPIs can change the gut flora a little bit, and change the gut flora, all of a sudden you have bacteria that may produce more ammonia, so they're at risk for hepatic encephalopathy and increased infection rates. If they can't sleep, the suggestion is hydroxyzine. And so early on, what about somebody that has NASH? What medication might you want to put them on? It's kind of almost counterintuitive.
because it goes to the liver.
Yeah, it goes through the liver. We worry about it all the time.
Statins.
Statins.
Yeah, statins are a reasonable thing to do in the instance of statin-induced liver failures.
It's a lot less, I mean, we're not even supposed to be checking liver
Right.
function after doing that. Actually, so they always recommend statins in NASH, but there have been some studies showing that simvastatin lowers portal hypertension. And so any patient with hyperlipidemia, you at least should be on a statin, but I think they're actually looking at using it kind of like a propanolol
Yeah,
or carvedilol. So it's really quite interesting. I'm not sure how that works.
yeah, I don't need, that's interesting. I do think if you get into somebody that's decompensated, remember, I think, what was the stat? Cardiovascular outcomes changed by 30%, well, treatment over 5 to 10 years. So it would be one of those medications that if you have somebody that's decompensated and is.
Yeah, if it's decompensated, you're not getting the benefit, but
But the place
again,
for it is for
I don't think
compensated.
we're aggressive enough in
Yep.
the compensated. The other thing with the statin was they showed decreased hepatocellular carcinoma in diabetics. And those were probably the only ones that were taking it. But
Yeah,
again, kind of interesting.
And I-
New things to try
oh yeah.
and not to avoid or stop, so.
And I think it's hard for people to be like, well, I have this potentially hepatotoxic drug,
Right,
and I don't want to give it to somebody with elevated
right,
LFTs.
you're trying not to do harm.
But I think it's a good thing, especially in the setting of NASH.
Yeah.
But you have to kind of use your
Noggin.
Noggin. And what I was
And your knowledge.
I just try to tell myself most of the drugs go through the liver,
Right,
But we had this kind of historic, the way the statins were sort of rolled out to us in the community was that we
It
had
was
to check
toxic.
it was toxic, and we had to watch liver function tests, and so we have this kind of
Some of them were pulled off the market because they were, but I don't
Mhm.
think any of them are out there. that
Yep.
can do that.
Vaptans. How about somebody for hyponatremia? If you have hyponatremia, you just can't manage. What do you guys think about that?
Love those Vaptans.
Yeah, exactly.
Except,
They work well. The only problem is, for unclear reasons, they are associated with higher mortality. So you can fix their sodium, but they tend to die at a higher rate. And because these people are chronically low sodiums, you'll see it. That's why these people walk in with a sodium of 120. They're also most at risk for demyelinating if they're overcorrected. So
yeah,
the
again, kind of
Vaptans,
more vascular.
yep, just they're so vasodilated. They have they have ADH around everywhere, and
Yeah.
so I would not treat with the Vaptan. Let's see, anything else? Oh, SBP, how do we make the diagnosis? We
More
tap?
than-
Tap greater than 250.
Yeah.
Femens.
Mhm.
This is interesting too. Now these people, when you have cirrhosis, one of the first things you see the INRs go up. They get thrombocytopenic due to sequestration of platelets. What should be your parameters?
This is always on the boards,
Yeah.
every time.
What's your parameters to say, gee whiz, it's okay to use a large...
His INR is 7. We better not tap him.
And we got this guy's volume expanded, so we're going to give him
He's
FFP.
gonna bleed.
We're going to give him a bunch
Gonna
of
bleed,
FFP,
his INR
right?
7.
What do you guys think? What do you... Oh, Ben's reading.
Okay to tap up to 8 and platelets less or greater than 20,000.
Yeah.
Yeah, that's a pretty good rule of thumb. Yeah.
And I have a little theory about that, because actually you tap these big, huge guys, and you know what happens? I mean, if you even use like a flexible catheter for your paracentesis,
I've had that where they
it
kink.
just collapses, and so I think you create your own pressure,
Yeah.
for that. But it's a very low risk type of procedure that you're going to hit any blood vessels or cause any bleeding. So I mean, it's all fluid. You're not going to get at anything. So
Yep, I agree. I only saw one that went bad, and it was sheer bad luck in that there was a vein inside the abdominal cavity that was nicked, and it didn't matter what their INR was, right?
yeah,
and it was
that's
just huge. They just happened to where their veins dilated happened to be down in the belly, and it was on the peritoneal side, so it was in, and it just
bad news.
bad news. And that's only one in many, many years.
Yeah.
How much fluid can you remove before you have to replace albumin?
5 liters.
Good. 6 to 8 grams of albumin, right?
Protecting you from hepatorenal.
Yep. I think that's all I
That's
got.
it. Should we go?
Yeah. Oh no, I locked you out.
I guess we talked too long, Dr. Birch.
We did. Even the federal government got fed up with it.
I know. They're the slowest moving thing in the world.
It was too much documentation.
So key points. Main causes in the United States currently of cirrhosis are alcohol, viral hepatitis, and NASH. And like Dr. Birch mentioned, we're going to start seeing shifts on that. Lifestyle modifications are important for survival and quality of life. So even if you don't have alcoholic cirrhosis, you better avoid alcohol. You should, even if you don't have viral hepatitis, you should get Hep A, Hep B injections. And anybody overweight is going to benefit from weight loss, even if you don't have NASH. So I think that's important to know. There's a little cross fertilization of that. Routine imaging is important once cirrhosis is diagnosed. You should know that ultrasound and CT both have low sensitivity for diagnosis in early cirrhotics, and actually MRI does too. So you can't be too falsely reassured that they don't have cirrhosis if it's early. EGD for varicose.
Spell checker.
Yeah. Should be done at initial diagnosis of cirrhosis, and then go for treatment is prevent sequelae and intervene as much as possible to prevent progression when sequelae occur. So, interesting disease, a lot of pathophys.
Yeah, for sure.
I like it.
Okay.